Okay, so hi everyone, I am Anuradhaa Subramanian. I'm a research fellow at the Institute of Applied Health Research, University of Birmingham. So with the recently acquired funding from National Institute for Health and Care Research for the Therapies for Long COVID study, we performed an observational study using our primary care data, which I will be discussing today. So SARS-CoV-2 infection, or the disease caused by it, that is COVID-19, has been observed to be frequently associated with a very wide range of symptoms. And we now know that these symptoms are persistent beyond 12 weeks of COVID-19 infection. We now call this long COVID or PASC, or post-acute COVID-19 infection. We wanted to explore the breadth and extent of the symptoms that are presented by the patients who are infected with SARS-CoV-2 compared to a closely matched comparative cohort of patients or control patients who were not infected with SARS-CoV-2. We also wanted to explore the risk factors of long COVID. And finally, we also wanted to see if there were any distinct phenotypes or distinct presentations of long COVID, and to see which symptoms commonly co-occur or cluster together in presentation of long COVID. So for this, we undertook a retrospective study using routinely collected and anonymized primary care data, a database called CPRD-ORM, between 31st of January 2020 and 15th of April 2021. We first identified a cohort of patients who were infected with SARS-CoV-2 based on their primary care coded records. We then restricted the inclusion to adult patients who were aged 18 and above, and especially those who were not hospitalized within 28 days of their infection. Following the identification of patients with SARS-CoV-2, we then selected a closely matched comparative cohort of patients who were not infected with SARS-CoV-2, but were very similar to the infected patients in terms of several features like age, sex, BMI, ethnicity, pre-existing health conditions, and the symptoms that they reported in the previous year prior to infection. This was important to sort of balance the several other confounders or several other factors that may contribute to the outcomes between the exposed and the unexposed cohort. We then pre-selected 115 relevant symptom outcomes to assess which of these symptoms were presented at a higher rate among the patients who were infected with SARS-CoV-2 compared to patients who were not infected with SARS-CoV-2. And these 115 symptoms spanning across 15 domains, and these domains were domains like breathing, pain, circulation, fatigue, cognitive health like brain fog, movement, sleep, and so on. We identified if the study participants were presenting with these symptoms based on their primary care records. We identified if they were presenting with the symptoms, whether if the symptoms were presented during the first 4 weeks of infection, or 4 to 12 weeks of infection, or after 12 weeks of infection. As you can see, we identified nearly 400,000 patients with SARS-CoV-2 infection based on primary care records, and we identified closely matched comparative cohort of nearly 1.9 million patients from primary care records. The mean age of the participants who were included in the study was roughly 44 years. 55% of the included patients were women, 64% of them were Caucasians. As you can see on the two columns, the baseline characteristics were very similar between the two groups of patients, that is the infected and the uninfected patients. Out of the 115 symptoms that we considered, 62 of the symptoms were significantly associated with COVID-19 in our study. The plot here presents the strength of association between COVID-19 and each of the symptoms reported. The farther the little dots are from the null effect towards the right, the stronger the association between COVID-19 and that symptom that is considered. As you can see, for anosmia, the dot is on the farthest right, meaning one of the strongest association with COVID-19 beyond 12 weeks of infection. So anosmia is presented 6.49 times, as you can see that, 6.49 times at a higher rate among those who were infected with COVID-19 compared to those who were uninfected with COVID-19 with SARS-CoV-2 after 12 weeks of infection. So the symptoms with the strongest association were loss of smell, that is anosmia, hair loss, sneezing, some sexual dysfunction symptoms like difficulties with ejaculation, reduced libido, and other symptoms like shortness of breath at rest, fatigue, pleuritic chest pain, hoarse voice, and fever. Several socio-demographic and clinical risk factors were significantly associated with the incidence of long COVID. So long COVID had several socio-demographic risk factors. Women were at 52% increased risk of long COVID compared to men. Older age was initially associated with a higher risk of long COVID only when you consider age as an explanatory variable. But when you look at other confounders, other variables, when other variables come into picture, it is actually, when you consider only age as an explanatory variable, however, when you consider other socio-demographic features and pre-existing comorbidities, older age was actually associated with lower risk of long COVID. There were several associations between the risk of long COVID and ethnic minority groups, especially among Black ethnic minority groups and other ethnic minority groups compared to white Caucasians. And the risk of long COVID was also increasing with increasing levels of deprivation. Smoking, former smoking, being overweight were also risk factors of long COVID. And finally, a wide range of comorbidities were also associated with long COVID. And these comorbidities were COPD, benign prostatic hyperplasia, fibromyalgia, anxiety, and so on. Finally, when we try to explore which of the 62 symptoms commonly co-occurred or clustered together, we found 3 distinct types of long COVID presentation. The first presentation, which we call the broad spectrum presentation, was the most common presentation of long COVID, presented by nearly 80% of the patients with long COVID. In this class, patients presented with a wide range of symptoms with relatively low burden. In the second class, or the second type of presentation, which constituted roughly around 5% of the patients with long COVID, presentation of symptoms were predominantly respiratory-related symptoms such as cough, shortness of breath, mucus, and phlegm production in excess, and wheezing. In the third class, all patients had mental health conditions such as anxiety or depression, with concurrent presentation of other symptoms like insomnia, brain fog, headache, and fatigue. So we had 3 distinct types of long COVID presentation within our study. We are now working towards publishing this study very soon, and hopefully it will be available to you all to read as well. Thank you very much for listening, and we will be open to questions.
Thanks very much, Anu. That was a really interesting, very interesting presentation and summary of this very large study. So we can open up now to any questions or any points of clarification. Please feel free to pose your question in the Q&A chat box, and we'll do our best to answer the questions. I appreciate that there's quite a lot of information in this presentation, so you might need a few minutes to think through your questions. Anna, would you be happy to stop sharing your slides at this point? And just while we wait for questions to come through, was there anything from other panel members that they wanted to add about this study, or anything they'd like to comment on, please feel free to do so. So just while we wait for questions to, oh, actually, no, we've got one that's just come through. There's a question here. Did you look at the duration of symptoms? Wondering if anyone gets better. Anna, would you like to tackle that question?
Yeah, of course. So duration of symptoms is a fairly tricky thing to assess using primary care data, which we have. But we did look at 3 different time periods in our study. That is the first 4 weeks, 4 to 12 weeks, and 12 weeks of after. And we did see the strongest association with the symptoms was during the first 4 weeks, and slightly lower strength of association in the 4 to 12 weeks, and an even further lesser strength of association in the 12 weeks or after period. But in the period that was 12 weeks or after, that's the largest period, we did not necessarily see how it got reduced, or how it changed in that very large window. It's a very large window, I do agree, but we did not really have the opportunity to see how it changed within that period. But that would be very interesting to look at.
Yeah, so thanks for that question, Catherine. I think it's a really important question, and one which we still don't have an answer to. Exactly how long do these symptoms actually last for? And as Anu mentioned, when you look at the immediate period after the infection, the risk of those symptoms is at its highest, and it does progressively the risk gets smaller and smaller over time. So that is reassuring, but what we don't know is, for those who do have those symptoms beyond 12 weeks, how does that then change? How long does it take for those symptoms to disappear? And we don't know. And I think one of the important research questions that we'll need to try to address is exactly that. And we'll need to look at people over a period of years, really, to try and establish exactly what the natural course of long COVID is, and also compare that to other viral infections, because there are other viral infections which similarly have very long-term symptoms, which we're still trying to understand and describe. I hope that answers your question, Catherine. While we wait for any other possible questions, Anna, was there any other sort of reflections you wanted to make about the study, or anything that you were surprised by, or anything else you'd like to highlight to those listening?
No, just really surprised, and want to highlight that the usual symptoms that are commonly reported, yes, they are fairly important, but what's important is also the symptoms that may numerically be smaller in numbers, but relatively speaking, they're also presented at a higher rate among patients with COVID-19. So basically, the extent of the symptoms, the breadth of the symptoms that are being reported is larger, and that should be considered. So we need to understand which symptoms need to be attributed towards COVID-19, and that's important.
We've got two other questions. At what point do you start getting worried that symptoms are getting too strong in the periods after the infection, to a point where you would expect the child to go to the hospital? So thanks for that question. So just to clarify, in our study, we specifically looked at adults, and specifically non-hospitalised adults. There is a separate study called the CLOCK study, which looks at children, and we don't specifically look at children in our study. But it's certainly an interesting question. At what point do people with long COVID, with their symptoms, at what point should they be going to the hospital? There are clearly some symptoms which require urgent clinical attention. So people who with long COVID frequently experience symptoms such as chest pain, for example, and those symptoms are can be related to significant heart problems. So symptoms like that, we would certainly recommend that anyone experiencing such symptoms should seek advice from a medical professional as soon as possible. And anyone who is feeling very unwell should be accessing the NHS. If they're feeling particularly unwell, that might mean going straight to hospital. Otherwise, it would mean contacting their GP or accessing NHS 111. Thankfully, the majority of people with long COVID wouldn't need to go to hospital, but actually need ongoing care to support the significant symptoms that they're experiencing over a long period of time. So I hope that answers that question. So there's another question from Danielle. Apologies if I missed this, but did you look at associations between those socio-demographic characteristics and the symptoms or symptom clusters? So Anu, would you like to answer that one?
Yeah, yes, of course, yes, we did. So, so for example, age, so people from class 3 was younger compared to patients in class 1 and 2. So patients with long COVID who were presenting predominantly with anxiety and depression were younger compared to patients who presented with respiratory symptoms or who belonged to the broad spectrum class of long COVID. With respect to sex, class 3 patients were more likely to be women compared to class 1 and class 2 patients. And with respect to ethnicity, class 1 patients were less likely to be Caucasians and more likely to be from ethnic minorities like being Asian or being from Black Afro-Caribbean community. Yeah, so we did observe socio-demographic risk factor differences across the three phenotypes of long COVID.
Great, thanks, Anu. So the next question was from Nikki. There appear to be several symptoms that appear in all 3 of the classes you showed. If someone with long COVID only has symptoms that are common across the classes, how do you know which class they fall into? So this is quite a complex question. So defining the classes is quite difficult. So we used statistical methods to define these clusters. So we used statistical clustering methods, and you're absolutely right, Nikki. There is overlap between the classes. None of them have symptoms that are completely distinct. But what the approach we've used does is it tells us which symptoms tend to present tend to present together rather than looking at individual symptoms in isolation. So many of the folks who appear in, say, the class which is predominantly with mental health and problems in relation to cognition, brain fog, and so on. They do have many of the wide range of symptoms, but virtually all of them had mental health symptoms, and in addition to symptoms related to brain fog and headaches. So that's how they would sort of be characterized, that they sort of distinctly had those groups of symptoms together as the key ones. And similarly, those who fell into the respiratory class, they particularly had symptoms like shortness of breath, cough, wheeze, and so on. And but in addition, many of them did have other symptoms like, fatigue and pain and so on. But they were still quite distinct in that they overwhelmingly reported respiratory symptoms. And then the folks who were in the main class, which was the broad spectrum cluster, they had a bit of everything. They didn't seem to have one symptom that stood out, but rather had a broad range of symptoms at a relatively sort of lower burden of symptoms overall in comparison to the other two classes. But yeah, it's very tricky. These groups are not completely distinct, and there's certainly overlap between them. But the approach we've used is, I guess, pragmatic enough that we hope they make sense, that they clinically make sense. Certainly the patients I've seen with long COVID, it seems to chime with my own clinical experience. But there are many other groups who are trying to characterize, what these different groups look like, because ultimately the purpose of this is to try and unpick long COVID. We don't believe that long COVID is a single condition, but actually it's a range of different conditions that we currently call long COVID. It could be better described as a syndrome, and a syndrome is really just a description of the symptoms that people experience. But underlying that are likely to be different disease processes. And we hope that by sort of defining how these different symptoms cluster, we may be able to at least make a start to understand what these different sort of diseases are, so that we can better treat them. So I hope that answers your question, Nikki, on the different clusters. There's another question from Catherine: what proportion of the cohorts were in each class? So Anna, would you like to answer that?
Yeah, so in the broad spectrum class of symptoms, there were about 80% of the patients who belong to that class, and the respiratory symptom, it was roughly 5 to 6%, and the rest of them, around 15%, were in the class with anxiety or depression. Yeah, so that was the distribution across the three classes that we found. And to also add on to the previous question, so sometimes even advanced statistical models, they say, so this patient is 50% likely to be in this class and 50% likely to be in that class. So to distinguish can be difficult, even with advanced statistical modelings.
And hopefully, as we get a better idea of what these different groups look like, we can start to inform clinical guidelines, because at the moment, I think, there's kind of a very blunt approach to managing long COVID, which is everyone is more or less recommended the same thing. But what we need to do is to tailor treatment towards, the types of symptoms that people report and what the underlying, physiology that's driving those symptoms. So that's where we need to get to, and we need research like this in order to be able to get to the point where we can give that more tailored care. Great. Well, I don't see any other questions, but we've still got 3 minutes left. So I think we'll hang on for a little bit longer just to give people a bit more time to answer any further questions if there are any. But one of the things just to highlight is that we would, very much like to signpost you all to the research paper itself. We're hoping there'll be a research briefing as well, which will be a succinct summary of the paper in due course. And we'll do our best to sort of highlight that to you all when it's available. Great. So I think we've got another question. How does someone like me, a long COVID sufferer, find out more in an intelligent setting? So I think hopefully this webinar is an example of how we can share information about research that's ongoing. I know many other research groups are also doing that. So I definitely encourage you to visit the websites of the various funded groups that are out there that are delivering long COVID research, and use those as opportunities to find out what webinars those groups are also delivering like ours. We also have a number of other webinars coming up about various other aspects of the study, and you'd be more than welcome to join those too. We'll have a Q&A at the end of each of those where you can pose your questions. There's there's obviously a very very strong patient voice which has really driven the research agenda. Many long COVID support groups who I do follow on Twitter and so on, who are often highlighting research findings. So I really recommend following those groups to find out more about long COVID research, and also reach out to those who are doing research in long COVID. Many of us are quite open to discussing our research and sharing our findings. So those are some of the ways of finding out a little bit more about long COVID. There's also a number of studies going on nationally and internationally where you can get involved as a patient partner, and that will hopefully also be a way of learning a bit more about long COVID and the kind of research that's being undertaken. So thanks very much for the question. I now make it 12:30. So I think we'll draw the meeting to a close here.